You are welcome to my channel. Today I'll be addressing how to treat upper gastrointestinal bleeding in an acute phase. Okay, someone with upper GI bleeding is right here with us. Without any further ado, first thing to do is check for the airway, the nostrils, the mouth, the ears, any bleeding, any rhinorrhea, any other secretion, any foreign body. Remove what should be removed, sunshine what should be sunshine. Move straight to the breathing. Okay, looking at the chest region, look at the neck, any intratracheal deviation, any obvious respiratory distress, peripheral cyanosis, central cyanosis, respiratory rate, auscultation, decreased air entry, obvious signs of pneumothorax or not. What is O2 sat? Then move to the C, the circulatory system. What is the pulse rate? What is the blood pressure? How about the temperature? Then, what is the vital signs machine telling us? Fluid in and out. Any dehydration here or not? Then search 2 IV lines. Pass the catheter. No, I mean blood catheter right now for drainage, okay? And search 2 IV lines. Large bore nails. Why that? One for fluid, one for investigation, prepare for blood transfusion. But make the assessment right now. Are we dealing with severe cases? Is it mild? If it is severe, do you think we have hypotension? Are we going into hypovolemic shock? Should we get prepared for blood transfusion? Are we going to have group and cross match? We'll get all that done right now. Then consult to gastroenterologist. We would need upper endoscopy right away. Then you've taken the first step. You can then give your high dose esomeprazole, that is proton pump inhibitor at 80 mg start. Then you have endoscopy done. But it is not in all centers that endoscopy will be available. I'm in a rural area or remote place, okay, no endoscopy at the moment. Okay, I'll go ahead with the second dose of esomeprazole after 12 hours. But in that case, the dosage will be reduced to half, 40 mg. If no more bleeding, oh great, and give another esomeprazole intravenously, 40 mg every 12 hours. I'll continue with that, or better still, put esomeprazole as infusion at 8 mg per hour for the next 72 hours if there is still active bleeding. Remember, you might not go through all this if you have endoscopy. We can also use pantoprazole intravenously, but no more lansoprazole intravenously because it has been removed from the market. You may give proton pump inhibitor per oral if you can't get intravenous formulation. If there's no active bleeding, then you can give per oral as 20 mg per day with the treatment of H. pylori. We can add erythromycin intravenously. Erythromycin, remember, that's an antibiotic, right? Macrolide, okay? We'll give that slowly, just at about 1 hour before endoscopy. Remember, octreotide will be very helpful here, and I have full presentation on octreotide right here on my channel. Please kindly take the time to check of that. So I will not go into details of the dosage of octreotide right now, so I don't want to weary you with too much info. Check octreotide on my channel. I'm going to find that. Okay, you are fortunate to have endoscopy in your center. All right, that's good. Then have therapeutic endoscopy then. So epinephrine with any of the following, either epinephrine with thermal coagulation, or epinephrine with hemostatic clips, or epinephrine with fibrin sealant or glue, or argon plasma coagulation. Just make use of what is available. Still, lucky to have therapeutic endoscopy done right. You can have temporary hemostasis in saline injection or hemospray. You can do a planned follow-up endoscopy. That is, you have a second look, okay? So have a second look to be sure that everything is in order. If you are fortunate to have endoscopy done, and you've done your therapeutic endoscopy, you've used either your epinephrine or whatever, and you have follow-up endoscopy, that is great. If that should fail, then you have surgery. Then you've resuscitated. The patient is stable, the bleeding is no longer scary, then we'll check for the vital signs. What about fluid in and out? Okay, then full physical examination. Mostly, this is likely going to be secondary to peptic ulcer disease, but then we just want to be sure, right? So thorough history of alcohol, history of anticoagulants use, history of antiplatelets, history of bleeding disorder in the family, history of trauma, blah, blah, blah. Now, then your bladder catheterization, right? Okay, we're now in the lab. For what? For APTT, bleeding time, PT, trauma time, RDW, von Willebrand fact, reticulocyte, complete blood count, H. pylori testing. We want to know. Okay, if you haven't made definitive diagnosis and you still want to rule out certain stuff, you can have thyroid function test done, liver function test, renal function test, ultrasound, and CT, particularly if you are concerned about liver problem, because liver problem will lead to bleeding. Remember, all causing factors except two are synthesized in liver hepatocytes. So you can have your ultrasound or CT scan done. Okay, you resuscitated the patient. Now you can do more. Stop whatever should be stopped, like advice against street drugs, cocaine, fentanyl, methamphetamine, and the rest. And certain medications, if the patient is on anticoagulant, check the dosage and know the reason for the prescription and contact the doctor who prescribed it or the pharmacy. Alcohol, must stop binging. Yeah, might be alcohol is even the major reason why he or she has presented. Then it is time to do away with it, or else he or she will come back again. Start what should be started. Do we need to transfuse this patient with blood product? Yeah. You've had your complete blood count done, right? You know all those parameters. Now go ahead with whatever is necessary. Start H. pylori treatment. Yes. If this is also, if it is secondary to peptic ulcer disease, which is the major cause anyway, and also viruses, okay, then we have to treat that appropriately. H. pylori. If there's DICA or sepsis, please treat. You can check my channel. There are separate full presentations, one on DIC, one on sepsis. And have a follow-up with the family physician or refer as may be appropriate. Now, lastly, we want to be able to make the prediction if this patient will come back or not. And the best way would be forest classification, which is not what I have right now here. But if you want me to have full forest classification presented, please can leave comment down. Okay, here is the scenario. I have active arterial bleeding, but endoscopy is not done, and I've treated the patient with only medication. you know what? He or she will come back in 80 to 90% of the time. Okay. Um, that is the probability, which is higher than having blood that is oozing without visible vessels. The probability of coming back in that case will be lesser compared to active arterial bleeding. Those with flat spots or clean ulcer base might reoccur but pretty low, about 5 to 10% of the chances of coming back. So with that, I've come to the end of this presentation. Thanks for listening. Remember to share this presentation with your colleagues. Remember to subscribe to my channel. I appreciate that.